Thank you for Sophion and the organizer for the kind invitation and also for this exciting meeting. So today I will talk about some allosteric inhibitors of calcium-activated potassium channel to try a novel approach to treat atrial fibrillation. So first of all, I would like to tell you some few words just to frighten you about atrial fibrillation. And actually, atrial fibrillation is the most common arrhythmia with a prevalence of about 1% of the population worldwide, over 70 million cases across the world. It's a progressive and chronic nature. It has a progressive and chronic nature with electrical and structural changes which reflect actually remodeling. Do you hear me? Yeah, it's okay. So, which reflect actually a kind of ionic channel remodeling and structural remodeling, which include inflammation and atrial fibrosis. So it's often associated with heart failure progression, embolic stroke, and increased mortality. It has a prevalence with aging population, like me, and it is often associated with comorbidities like hypertension, diabetes, valvular heart disease, and heart failure. So what is the status of the current therapy? In terms of the current therapy, it includes the pulmonary vein isolation, which is effective but only in selected cases, and it has several disadvantages. It is an invasive method, it's costly, it has often life-threatening complication. It has a partial efficacy because it has recurrence. And we have AF, atrial fibrillation recurrence, that occur in up to 70% of the patient with persistent atrial fibrillation within a year. The therapies also includes pharmacological therapy like sodium, potassium, and calcium channel blockers, but also they have a limited efficacy because of the risk of pro-arrhythmic effect and side effect. And it is important to notice that all the current existing therapy for atrial fibrillation do not reduce atrial fibrillation progression of the substrate. They do not treat the remodeling, the atrial inflammation, and the fibrosis. So from our previous work, we revealed the existence of a completely overlooked cardiac target in the heart, mainly the SK4 calcium-activated potassium channel. And these channels are important for the late repolarization of the atrial action potential, presumably by establishing a kind of vicious link between abnormal diastolic calcium handling, calcium overload, or diastolic calcium leak, and the SK4 channel hyperactivity, which provide actually a substrate for reentry and AF promotion. So we hypothesized that SK4 potassium channel are kind of pro-arrhythmic channel and pro-inflammatory, and that their pharmacological inhibition will not only prevent atrial fibrillation induction, but will also prevent AF progression and atrial remodeling and fibrosis. And the main goal of this project was to target the SK4 potassium channel and identify a novel selective SK4 channel blocker to treat atrial fibrillation. So as I mentioned, SK4 channels are highly expressed in the heart. They are predominantly expressed in the atrium. This is an example of a rat atrium, where you see the expression of SK4 potassium channel. They have a kind of sarcomeric pattern of labeling, and they co-express with alpha-actinin. There is more than 9-fold more expression of SK4 potassium channel in the atrium than in the ventricle. Notice that the SK4 channel are also expressed in blood vessels. They're expressed in endothelial cells and capillary or vascular smooth muscle cells. The same situation holds also in human heart, And we have more than tenfold expression of SK4 potassium channel in the atrium than in the ventricle. So what about SK4 potassium channel? These channels are not activated by voltage. They are not voltage dependent. They are calcium activated. And like many potassium channels, they are tetrameric structure. And thanks to the recent cryo-EM structure given by Rod McKinnon, we know that this tetramer in each subunit, we have each subunit that is tethered, that is interacting with one molecule of calmodulin. And the apo-C lobe of calmodulin is interacting with the proximal C terminus of the channel, while the N lobe is mobile, and when there is an increase in intracellular calcium, the calcified N lobe will interact with a very important S4-S5 intracellular linker that will produce a change in the conformation, will pull downward and outward this segment to open the gate of the channel. So these channels are activated by increasing intracellular calcium because they calcify the N lobe of calmodulin and they gate the channel. The affinity is quite high. We measure the affinity with an EC50, which is just above the resting calcium concentration, EC50 of about 65 to 70 nanomolar. And we showed that actually these channels are also activated by PIP2. This was not known before. And we found that the affinity for PIP2 is about 150 nanomolar, so a high affinity for PIP2. We mapped the site of interaction of PIP2 using a molecular dynamic simulation and molecular docking, and we did retrospective physiological validation. We found that the PIP2 molecule is docking to a pocket at a critical site at the interface of the channel and calmodulin and the proximal helices of the C terminus of the channel. So one molecule of PIP2 will interact by providing hydrogen bonding interaction between the oxygen of the head group of the phosphate head group, and will actually make hydrogen bonding interaction with the guanidinium of several arginine in the pocket. Arginine 180 and 191 in the linker, the intracellular linker S4-S5, and arginine 352 in the proximal helix B of the channel. It also interacts with the lysine 75 of the calmodulin itself. Lysine 75 is located in the linker that connects the two lobes of calmodulin. And of course, in terms of validation, we see that the wild-type channel is activated by increase in the cellular PIP2 concentration. And of course, when you mutate all of these arginine in the pocket of the PIP2 interaction site, you lose the stimulation of the channel by PIP2. So our main goal was to try to target this channel by blockers. Why? Because all currently known blockers like TRAM34, Cenicapoc, NS6180, or clotrimazole are interacting with the pore, and most of them have very poor bioavailability, and they have liver toxicity because they inhibit the cytochrome P50 in the liver, so they cannot be used for clinical development. So we aim to target, and this was very challenging, we aim to target the channel at the heart of the gating machinery, okay? This interface between calmodulin, the inner boundary of the channel, and PIP2. And we started with a template which is called 1-ABO. 1-ABO is this benzimidazole structure. It was a known SK4 channel opener, okay? And some years ago, it was shown that this opener may interact at the interface between the channel and calmodulin. So we started with this template, and of course we modified it. And we changed the benzimidazole moiety by a benzoxazole, or more precisely, a benzoxazolone moiety, okay? And we added to the nitrogen of this ring an aliphatic chain of 7 carbons, and we checked what happens with the channel. And of course, this is a potent inhibitor. We have an IC50 of about 8 micromolar. We have no much more potent inhibitors that were at sub-micromolar ranges around this structure. And we wanted to know what is the site, what is the pocket that for which this blocker interact with the channel. So we did, again, molecular docking, MDS, and electrophysiological validation. And we found that this blocker is sitting very close to PIP2 at the interface of the channel and the calmodulin, and of course of PIP2. And the ring of the blocker, so this benzoxazole moiety, is engaged in hydrogen bonding interaction with this arginine 191. You remember, the one which is located in the S4-S5 intracellular linker. It is engaged also into pi-pi interaction with this histidine 192, again in the S4-S5 linker. And it is also interacting, but in a very curious way, because this aliphatic chain causes a steric hindrance with the calcified N-lobe of calmodulin. So in the presence of the blocker, the calcified N-lobe of calmodulin cannot interact properly with the channel and cannot open the channel. It's actually an allosteric blocker. This is the blocking effect of the molecule in macropatches. But when you look at the effect of the blocker at the structure, at the heart of the structure, you see that the blocker is actually clashing with the N-lobe of calmodulin. Okay, so it prevents the calmodulin N-lobe, the calcified N-lobe, to interact properly with the channel, and this is actually translated in the calcium activation curve of the channel. This is the calcium activated curve without the blocker, and this is in the presence of 10 micromolar of the blocker. We switch from an EC50 of about 65 nanomolar to more than 430 nanomolar. So this blocker does not interact with important cardiac channel, does not interact with the ERG, the IKS, the KV1.5 and KV2.1, which are highly expressed in the atrium, and does not interact with the other isoform of SK1, SK2, and SK3, which are expressed also in the heart. Why they do not, it does not interact with these other isoform of SK channel? Because, as I said, the molecule is interacting with this arginine and this histidine, arginine 191 and histidine 192 in the S4-S5 linker. And the other isoform, these two residues are not the same, and they are replaced by an asparagine and a threonine. So the blocking effect is quite specific in the SK family, quite specific to SK4 channel. Okay, so then we checked. Finally, we wanted to target the heart and the atrium and atrial fibrillation. So we found that the blockade of the channel by this blocker, which we called BA6B9. Okay, sorry, I forgot to mention the name. So BA6B9, created by Bernard Attali, but it's not an ego problem. Just for the synthesis, it was more, it was easier to name it. So it does block, or it does prolong the refractory period in the atrium and the AV node in a rat isolated preparation, the Langendorf preparation. And of course, we checked that the very known SK4 blocker, TRAM34, does the same. So it increases the refractory period in the atrium, in the AV node. It does not modify the refractory period in the ventricle, and this is very important. It does produce a bradycardic effect, so it reduces the heart rate, and it prolongs the PR interval. Then we found that this blocker, BA6B9, reduces the atrial fibrillation induction and duration when we do tachypacing of this heart and we add carbachol. This is a very known protocol when you induce atrial fibrillation in the rat and you do it by adding carbachol and tachypacing. And this is the result, so it reduce or inhibit the induction and reduce the duration. So then it was very important for us to check in vivo what is the impact of this blocker in an in vivo model. And we choose the in vivo model of the heart failure rat model. When these animals, when you induce heart failure, they are more susceptible to atrial fibrillation when you do tachypacing, okay? So for that purpose, we took rats and we induced the myocardial infarction by the ligation of the coronary artery, very well-known preparation. And we measured, of course, the ejection fraction of these rats, taking care that all the ejection fraction, when they are not actually dead, because sometimes the myocardial infarction is so strong that the rats are dying. But we checked for the surviving rats that the ejection fraction is less than 40%. Then we separated in two groups. So the groups that receive the vehicle and the group that received the SK4 channel blocker 1 week after the surgery, okay? And we followed up the system for 3 weeks. So it's a procedure that takes 1 month, okay? And we found that indeed this blocker will reduce, will prolong the refractory period in the atrium, also in the AV node. It does not affect the refractory period in the ventricle, and it reduces very significantly the induction and the duration of atrial fibrillation triggered by tachypacing. As I said, does not touch to the refractory period in the ventricle. It does not affect. These are measurements in vivo, so we could see in the electrocardiogram that the QT interval is not modified. Then we checked what happens with these series of rats with the same model, with the heart failure model. We cut in slice and we checked what happens in terms of the fibrosis, the atrial fibrosis. SK4 channels are not only expressed in rat atrial cardiomyocytes, but are also expressed in fibroblasts and in macrophages. And all of these three types of cells are possess the inflammatory signaling machinery, notably the NLRP3 inflammasome, that is activated during the atrial remodeling, okay, during the atrial fibrosis in animal models, but you see also this activation of the NLRP3 in patients suffering from atrial fibrillation. And what you see here is the staining of the alpha SMA. Alpha SMA is a marker for fibrosis. This is the alpha smooth actin. And you see that in the control animal, the animal that do not undergo surgery, they do not exhibit the myocardial infarction, so they are healthy animal, very little expression of the alpha SMA. But when you look at the vehicle-injected rats that possess or they exhibit the myocardial infarction, there is a huge increase in the alpha SMA, so which actually reflects the atrial fibrosis. And in the presence, so this is the preventive treatment with this blocker of SK4 for 3 weeks, one injection daily at 20 milligrams per kilo, and you see that you reduce significantly the atrial fibrosis process. Another interesting feature is that during this, in this same heart failure rat model, we have an upregulation when the animals suffer from the myocardial infarction. There is an upregulation of the SK4 channels. That's why we hypothesize that these channels are not only pro-arrhythmic, but they are also pro-inflammatory. And here you can see the staining of the SK4 in control rats that were not undergoing surgery. They do not exhibit the myocardial infarction. But when you look at the animal, the vehicle-injected animal, there is a huge upregulation of the SK4 channel, which is inhibited by the preventive treatment of the SK4 channel blocker. The same feature was observed in the epicardium of the atrium. This is really a typical feature of atrial fibrillation and atrial fibrosis in the patient. So you have the same inhibition by the blocker of the alpha SMA upregulation. This is here, of the alpha SMA upregulation and the upregulation of the SK4. And then we looked at the NLRP3, so the marker for inflammation, and we found in the same heart failure rat model, so this is the staining of NLRP3, the control rats do not express or very little express NLRP3. Of course, they do not exhibit myocardial infarction. But then in the vehicle injected, we have a huge increase in the NLRP3 and depletion or significant inhibition by the SK4 channel blocker. Finally, this is the last slide. We looked at the expression of connexin 43 in the atrium. And in the control rat, again using the same heart failure rat model, in the control rat that do not express the myocardial infarction, the connexin 43 is typically exhibit a typically transversal expression. But then, when you look at the vehicle-injected rats, there is lateralization of connexin 43, and this is a very well-known feature of this pathology. And when you inject, when you have the preventive treatment with the SK4 channel blocker, we restore the typical expression, the transverse typical expression of the connexin 43. Just to conclude, so we found that the SK4 potassium channel is a novel cardiac target, especially to treat atrial fibrillation in the context of heart failure. This is a very frequent comorbidity. We succeeded to target in a new place the channel, not in the pore, but in the interface of the calmodulin and the PIP2 and the inner boundary of the channel with this new allosteric blocker. We found that this blocker will increase the refractory period in the atrium, in the AV node, but not in the ventricle. And this is typically the feature that you want when you want to control the rhythm and the rate in atrial fibrillation. More importantly, we found that this blocker will reduce atrial fibrosis, the upregulation of the NLRP3, so the inflammation, and the upregulation of SK4. So in conclusion, we think that targeting the SK4 channel, first of all, is the new therapeutic approach to try to treat atrial fibrillation. And it does not provide only rate and rhythm control, but also reduce all the feature of the atrial remodeling, the atrial fibrosis, that is a kind of new approach that we would like to pursue on this pathology. And we'd like to thank the people that did the work, especially Shira Bourg and Asher Perez, and people, Elvira and Advad made the molecular dynamic simulation and molecular docking, and Yoram Etzion in Ben Gurion University did the in vivo heart failure rat model. So thank you.
So maybe we have time for one or two quick questions. There was one here, some at the back as well.
Thank you, Bernard. I apologize if I've misheard this or didn't pick this up, but most of your experiments, you've applied the new drug and then you've done your insult. So can you reverse any features if you go the other way around?
No, you didn't. You did.
I picked it up wrong.
No. We did first the insult, so the surgery. 1 week after the surgery, we injected IP, the compound.
Excellent. Okay, thank you.
I think there was some.
Thank you for the talk. Calmodulin interacts with a number of channels. So is your binding site in the S4, S5 linker and those residues totally specific to SK4?
It's a very important question. Indeed, the site is in the interface between the inner boundary of the channel and calmodulin. But this interface is very specific. We have 2 examples. It does not interact with the IKS, and the IKS is a complex with the KCNQ1, which bind calmodulin, and the other isoform of the SK. So the SK1, SK2, SK3 are also tethered to calmodulin and does not affect them. So it's a very specific interface.
Questions here?
Thank you so much, Bernard. It's really nice talk. My name is Yan Wen from Scientifica. I have a question about the ex-vivo length of heart experiments. So it seems like the PR interval and also RR interval has been reduced. Do you think your new drug may have some effects on the sinus node disease, for example, sixth sinus syndrome, that kind of?
Yeah,
Thanks.
we are actually doing a collaborative experiment with Matteo Mangoni. He has nice mice model for the pacemaker. Indeed, the SK4 is also expressed in the pacemaker. That's the way it was discovered in the heart. So it does have a bradycardic effect.
So, if I may, very nice talk, really. The reduction of fibrosis that you see with the inhibitor, do you know if this going by a blockage of SK in macrophages or blockage of SK in the cardiomyocytes? And if you inhibit macrophage inflammation with other means, do you get the same reduction in fibrosis?
Yeah, it's a very, very important question. We still don't know. We believe that the main target is the cardiomyocyte site, but it does also inhibit the SK4 macrophage channel. That's for sure. This is one important point is that thanks to the redundancy of potassium channels in these immune cells, macrophages and also T cells, B cells, this channel was first discovered in these cells. Thanks to the redundancy of the potassium channel and notably the Kv1.3, for example, in T cells and in macrophages, we don't have, problem with the immune system. This was our first concern to see that the immune safety was preserved. And thanks to God, we have redundancy of channels. So.
Merci, Bernard. Thanks. Thank you.